Everybody, it is time now for Health Talk, and we are. Let me make sure we get everything plugged in here, okay, for our good friend John. Good morning, Mr. King, sir.
Hey, good morning, Peter.
How's it going?
It's going great.
All right, we have a great guest here in the studio today. Not his first rodeo, though. Dr. Barnett Fausett is joining us this morning. He is a perinatologist at Community Medical Center. I rehearsed that more times than Jimmy Kimmel did at the Oscars last night.
I'm glad.
Which means we might need more
here's
practice.
the right envelope. Yeah.
And the winner is me. No, just kidding. Yeah. So welcome to the show.
Thank you, Peter.
All right.
Glad
So now, for those who don't know, as I pronounced it correctly, what does a perinatologist do?
We take care of complicated pregnancies. So women who have troubles or have interesting things going on in their pregnancies.
Mm-hmm.
So is it
moms and babies? Sorry.
Is it so you deal with the babies after as well?
Not much, just for a few minutes.
Okay, gotcha.
Make them cry, make them holler if we can, and pass them off to the pediatricians or the neonatologist. I work with the neonatologist a lot. A lot of the babies that I take care of are born really early, and so they end up taking care of them.
Are you kind of like a pregnancy whisperer? You kind of know the
That's
problems
right.
before they come? I mean, can you look at someone and be like,
right.
you're going to have a difficult pregnancy?
Oh, well, not quite that good. But,
okay.
I did have a fun little hat that says, perinatologist, we see the future. You know? We do a lot of ultrasound, so we get to see them early.
Sure. I like my wife.
know.
My wife does the same sort of work, not your job particularly, but delivering babies. And there's one that says RNs helping people out.
There we go.
Okay.
I like it.
But seriously, folks. All right. Now, one of the things we wanted to come by and talk about today was a program called Safe Passages. And this is great because my wife, when my kids were born, had a really, really tough time. Our first one, over 30 hours of labor. It was really, really hard. And so one of the things that she did after my son was born was grab me by the throat and say, vasectomy.
We're not doing this again.
He always says throat, but I'm not sure.
She could reach that high. But anyway, tell me the difficulty that obviously everyone knows that many times childbirth can be painful.
Right. It is. And dads watch that by observation, and moms know it, of course. But the Safe Passages program, back when I was active duty and before coming up here, we had the Department of Health and Human Services had a bunch of hospitals, including military hospitals, who joined with them in this notion of trying to reduce harm, iatrogenic harm to people in the hospital. So things that happen that we cause, that sounds bad, that we cause in the hospital. But and the government came to us, the leadership, I was one of the leaders in obstetrics in the services for the Air Force, called the Surgeon General Consultant for Obstetrics. And they came to us and said, we want you guys in this year of doing this program with Health and Human Services called Partnership for Patients. We want you to focus on reducing severe lacerations during childbirth because we've got data on that, and we want to see how you can do. And so, interestingly, there were three of us, an Army and a Navy and an Air Force Surgeon General Consultant.
No Marines.
No Marines. The Navy takes care of the Marines, the Navy physicians.
Right,
but we got together and started working on this, and I shouldn't say this. I've been calling it in my publication services X and Y, but here I am. I was an Air Force guy, so I'll spill the beans here.
Okay.
But what we did in the Air Force was came up with a specific program that we wanted to use and implement across the service. And the Army and the Navy, my Army and Navy colleagues, gave some direction and encouraged people to work on reducing perineal trauma, so trauma to the genitals during childbirth, and they just kind of encouraged everybody to do that. And we came up with a program we call Safe Passages. It's basically an acronym for a series of interventions that can be done to reduce the likelihood of having a big tear. Our goal was to do that in such a way that we wouldn't actually increase other trauma. So one good way to reduce all the trauma to the genitals, if you're having a baby, is just to bypass the normal route of delivery and do a C-section, but that wasn't our goal because I would consider that trauma also. So the goal was trying to reduce trauma to moms overall and babies in the childbirth process, and that's what the Safe Passages program was.
Now, I know you have a long acronym for what is involved in Safe Passages, but before we get there, I'm curious, do you have, since you're in the military, and I know they like to keep track of all the numbers, how did it work out? I mean, did you have an improvement in the number of, a decrease, I should say, in the number of traumas?
Yeah, it was pretty amazing. We ended up taking the data from the year before we instituted the program and comparing that to about a year and a half after we instituted the program, and looked at the outcome. And we had about 500,000 deliveries as baseline, and about 250,000 deliveries to follow. And we compared how we did in the Air Force with the Safe Passages program to just sort of normal encouragement. And it turned out that and I went and did some simulation training to many of the hospitals. Didn't get to all of them because of government budget cuts, but got to about half of the hospitals where we did on-site training with simulators and education. And in those places where we went and did on-site training, we reduced the 3rd and 4th degree perineal laceration rate. So that's bad perineal trauma by 300%. And at the same time, overall in the Air Force...
What is 300%?
Right, 3 times, yeah. We cut them by 1/3. Maybe that's a bad thing to say.
Yeah,
cut them by 1/3. But we reduced them. How's that?
There you go. You sewed up that problem quick.
Yes, we did.
Yes.
We fixed it.
Oh boy. No. Forgive me. I'm the ignoramus in the group here. Okay.
I knew it was going to happen.
Thanks, Peter.
Even though my wife's had 2 kids, and I was there for both my children's births. It just seems like there's an engineering problem from on high.
Right. Okay.
Big baby, small opening, time to come into the world. Okay, so
what do you do?
What's going on here? And how do you? What are the techniques? And is there technology involved, or is it mostly relaxation, or waiting until the position is right, or what makes it better? What makes your situation better than the old way of doing things?
Right. Oh, that's great. There are simple things. The first, the Safe Passages. The first S is actually talking about perineal massage. So the perineum's that the back side of the vaginal opening, and what happens is that there's good data that if women will start massage of the perineal area to kind of stretch and allow it so that it can stretch when the baby's born, then that actually cuts the risk in half, as an example. So there's a lot of data out there, but we don't typically teach that or encourage that. So that's one, simply one.
It's an uncomfortable subject to bring up,
right.
Usually, in conversation.
Right. So, but normally...
Unless, of course, you're pregnant.
Or on top of that.
Pregnant.
Yeah.
Right.
Go ahead, yeah.
No, but what we do is encourage women to start in the last month of pregnancy to stretch and get those tissues ready to be able to deliver. It's just like any athlete who's going to go through, any sport. You kind of want to stretch and get those muscles ready to perform.
If you don't stretch your legs before you run the half marathon, you're in big trouble.
That's right.
Yeah.
That's exactly right. So that's one of them. And the other thing you do, part of stretching, is warming up. One of the interventions is to apply a warm compress, which is just something warm on the perineum right before delivery. That's another simple, makes sense, right?
Sure.
One of the interventions is to try to encourage the baby to look down when the baby is being born. So rotate the baby into what we call a position of occiput. So that's the back of the head anterior. So the back of the head facing up. And that actually makes it so the baby's head shape is most narrow as the baby's being born. So if the baby's looking up, it's bigger than if the baby's looking down. That may not make sense, but
sure.
Babies have soft spots, right? They can mold. The soft spots are because all the bones of the head are not fused, and that allows babies to change shape a little bit.
They have pictures of me when I was a guy. I looked like one of those Saturday Night Live alien guys.
Right.
Conehead,
With the big
right.
cone
Conehead.
in their head.
Right.
Yeah.
Yeah.
Hey, we're up against a break. So if you have a question for Dr. Barnett Fausett joining us here this morning, hey, this is a great topic because everybody's got to be born.
That's
So,
right.
so why not make it as safe and as comfortable as possible? 721-1290 is our number, 1-800-568-5309. You can also make your comment on our Facebook page. We're coming right back. And we are back on Health Talk. 721-1290 is our number, 1-800-568-5309. John King, and joining us in studio from Community Medical Center, Dr. Barnett Fausett.
And this episode is brought to us by the letters S, A, and F so far, but I think we're not quite yet to the letter E.
Yeah. Well, jump right on E.
Go for it, yeah. Because I didn't realize Safe Passages was actually an acronym. So this is, a rather complicated acronym,
Right,
but
right.
go ahead.
Well, E is actually eliminate episiotomy. Probably people are familiar with that, which is basically a cut that doctors would make to kind of open the space and make more room. But there's good data now that if we do that it actually just facilitates bigger tears in the long run. And so there's now good research to say don't do episiotomies. And so it should be. It's not there. There are probably a few instances where it makes sense to do that, but they should be very rare. Whereas I remember when I was training. That was the goal basically every time, is to make more room that way. But so eliminate episiotomy.
Well, nobody ever asked Mom if that was a good idea.
Right.
Well, do they ever? I mean, I'm curious. I mean, I've watched a couple of births.
Yeah.
My two or
Right.
three so far. They were all very different. One was a C-section. The other ones were natural births, etc. But there was a discussion with the person working, do you want to try to do this or not? That sort of thing. Does that happen in clinics still?
Well, women certainly have preferences and ask for certain things to be done. And the one argument for doing episiotomies is that it made for nice straight tears that were easier to sew up. And sometimes there are other tears that are a little bit disorganized, I guess I'll put it that way. And so I have had women say, just, make an episiotomy. But really the data are very strong that at least doubles the risk of a big tear. And the problem with the big tears is not just that they're deeper, but that they can result in lifelong problems. Some women who have these big tears have troubles with continence and so forth for their whole life. So it is a serious thing trying to reduce big tears.
Now, did you quit with SAFE, or is all of Passages an acronym as well?
All of Passages is
Oh, my goodness. All right. So let's go with
Is there a Guinness record available for this sort of work?
No. P we talked about already, and it's place a warm compress in the second stage. So, and that's the last part of labor and delivery, where the baby's getting ready to come, is just starting to warm the perineum. And the next two, the A and the S, really talk about something that you mentioned, Peter, and that is relaxation. Is if the perineum can be relaxed. One of the things that for years has gone on between midwives and physicians is midwives arguing about certain positions for childbirth, saying laying on your side reduces big tears, and not laying on your back with legs up and back. And for many years, physicians have had women deliver laying on their back with their legs up and back to sort of make more room. And it turns out that that actually tightens that area and puts stretch on it. And so moving the legs forward and bringing the legs together at the time a baby's born actually reduces relaxes the perineum and allows babies to deliver more easily. So that's what those two are, is getting the legs together and down. And I think that's made a huge difference. So it's not really whether you're vertical or on your back or on your side or whatever, but the legs need to be closer together and extended rather than being flexed. So that's the first A and the S. You want me to go on?
We're in this deep. We're going all the way.
You're on a roll, Doctor. Go ahead.
All right. So the second S in Passages is just supporting the perineum. So specific hand positioning. Interesting. There were a couple of studies done in one in Holland in the Netherlands and another from Norway where physicians and midwives recognized that their third and fourth degree laceration rates were going up. And so they thought, well, what can we do about this? Let's go back to some of our old ways of the way we hold actually the head and the perineum as the baby's delivering. And these guys went around and they went back to their old way, and they actually described a specific way of holding the hands and went around and made everybody, even very senior clinicians, go back to a certain way of holding their hands at delivery. And so, and as they did that, they cut their rates in half. And there's a couple of big trials that show that, and so we tried to teach that.
But when you say holding your hands, the listeners can't see your hands. Yeah. So are we talking about holding the hand of the person giving birth, or are you talking about a certain way of catching the baby?
Head.
Okay.
Yeah, a certain way of catching the baby, I guess. That the hands help support the perineum and at the same time guide the baby's head in the best direction to reduce the likelihood of tear. Same thing, just kind of guiding them safely, but very specific, interestingly enough. So I mentioned the A in passages is aim lateral if an episiotomy is needed. And basically that's called a medial lateral. So if you are going to make an incision because you need more room, that rather than going down the middle towards the back where you're more likely to tear into other structures, that the incision should be made to the side. Now, the Europeans have been doing that for a long, long, long time, and we have typically done down the middle incisions, and people have been afraid that there's more pain and more bleeding with the sideways incisions, but it turns out that that's probably not true. So aiming lateral, if you have to do an episiotomy, there's some research that if you are doing a vacuum or a forceps delivery, that actually you reduce the risk of tears by actually performing a lateral episiotomy. So not that we do that every time, but that's one thing. The G is go slow. Typically have the mom stop pushing right as the baby's delivering so the baby can go real slow and not go fast through as the baby's being delivered. And then the E is actually excelling at operative delivery, because our goal was to reduce the operative vaginal delivery, normal delivery. So that means getting really good with forceps or vacuum if you need to do that. Because remember, our goal was to reduce overall trauma, so we don't want to increase C-sections. And so there are some women who maybe their babies are in trouble and need to come out more quickly or whatever, and so you do the forceps.
Now, this mnemonic is just something that you run through, or does the patient also? I mean, do you get to the G in passages and tell the lady on the bed, remember, passages go as slow as possible during this part of the process?
It's really been a provider, primarily the delivering people who have been taught this and encouraged. But women are educated, they're smart, they know what they read about things, they have desires for how they'd like things to be managed, and they certainly come in and do that and talk to you about it. And this gives us a chance to talk about some specific things with them ahead of time, and that does work out well.
We're going to come right back. 721-1290 is our number. Dr. Barnett Fausett. I'm really interested to talk with you about your conversations with first-time moms, okay, who've never gone through this before. A lot of nervousness, a lot of hand-holding. So speaking of holding hands.
We're missing the last S still.
Yes, we got to get the last S. We'll be right back with more of Health Talk coming right up. Okay, we're back on Health Talk. 721-1290 is our number, 1-800-568-5309. We have one more letter in our acronym to go through, and that's S.
The last S.
Right.
Is do a superb repair if there are lacerations. So, of course, they're going to happen sometimes, and we do all we can to reduce the severity and the frequency, but ultimately what we did was go around and, again, teach very carefully about best methods to repair.
Now, one of the things that really helps when you go through this process is reality.
Right.
Because when we had our children, every single possible thing that could have gone wrong, I planned for as the husband, right? and I'm like, well, this is likely to happen. This is what we'll do if this happens. Yada, yada, yada. How often does the tearing and the ripping actually happen?
Well, it depends on whether it's first-time mom or mom who's had children, because the bad lacerations are less common in women who have had children. Makes probably sense that if the tissues have been stretched and a baby's been born, they do better. So that's part of the question. And then the severe lacerations, the numbers we're talking about are in the 3 to 5% range, and it's higher if there are operative vaginal deliveries involved, so with forceps and vacuum and so forth. But
so are you in on the initial conversations when they come in, especially the first time moms, and or during the whole prenatal thing as well? I want to introduce you to Dr. Fausett, because he could be helping you and working with you.
Not so much. At least in town here, especially, I function as a consultant to help the other OBGYNs and midwives when they're pregnant, when moms have complicated pregnancies. But this notion of safe passages, we just published on this or presented this at the Society for Maternal Fetal Medicine meeting just last month down in Las Vegas, and had a lot of excitement about it across the country. And it's actually a worldwide meeting where people get to come and hear. And so they're starting to apply some of these things. So we have posters that we've made that can be, and a training program that's online that physicians and midwives and so forth can get to.
We got about 30 seconds.
Okay, so. Right. So, but anyway, that's we get a chance to talk to them by teaching, but not so much one-on-one. You did ask about first-time moms, and yes. I guess I'd just say this, Peter. One of the A was, this is kind of a scary subject, and I probably should end this by saying this. The A is alleviate fear.
There you go.
And the last thing I want is everybody coming really afraid. Interestingly, Mother Nature made it so that if we are afraid, those muscles clench down.
Tighten up,
so
right.
we could run away. We have to be relaxed to do this. All's well.
And we're completely out of time. Doctor, thank you so much.
Thank you.
Appreciate it. That's going to do it for Health Talk. Stay with us.